Welcome to Derm Drop, your TLDR in dermatology. I'm David Sider, your host, bringing you quick picks from the literature and other sources in the dermatology community that are interesting and impactful. Episode 6 starts with chronic hand eczema. Did Big Pharma just invent a disease to sell a product? Or have the splitters finally triumphed over the lumpers? With all the pre-marketing chronic hand eczema disease state awareness content Leo Pharma has been flooding the US derm channels with, you might be wondering what all the hype is about and whether it even matters. Spoiler alert, it matters. Remember, eczema is a morphology, not a disease. When it happens on the hands, it could be atopic or contact. Contact could be irritant or allergic. It could be two out of the three or D, all of the above. Figuring out which is difficult and time consuming and maybe impossible. Because AD involves barrier dysfunction, thanks filaggrin gene mutation, which results in vulnerability to irritants and predisposes patients to the development of allergies, and vice versa, as repeated environmental exposures can drive epigenetic changes. So around we go in a loop of physical factors, chemical mediators, and immune activation. And you thought the itch scratch cycle was bad. In the meantime, patients want their bleeding, painful cracks gone now. They want to work, shake hands, be pretty, and make love. So you better cover all those bases. Topical steroids, the usual concerns of atrophy and dyspigmentation apply, plus systemic absorption. Remember those open fissures? Plus the real, albeit rare, possibility of topical steroid withdrawal. Oral immunosuppressants, cyclosporine is not a long-term solution for anything. Oral retinoids, alloretinoin works better on hyperkeratotic than dyshydrotic phenotypes, of which only about one-third of patients respond. And it's not even approved in the US. Biologics, great in atopy-driven cases and can indirectly reduce contact exacerbations by repairing the barrier, but they may be too targeted to work for all etiologies. JAK inhibitors, they check the most boxes because many CHE cytokines pass through the JAK-STAT pathway. In CHE, the innate immune system gets activated as damaged keratinocytes release IL 1 alpha, IL 1 beta, IL 6, and TNF alpha. And the adaptive immune system brings its crew to the party. Th1 cells produce interferon gamma and IL-2 in irritant and allergic variants. Th2 cells release IL-4, IL-5, IL-13, and IL-31 in atopic patients. And Th17/Th22 upregulate IL-17 and IL-22, resulting in keratinocyte proliferation. With Th1/Th17 predominant in psoriasis and Th2 predominant in atopic dermatitis involved, you could almost say CHE is a combination of the two. Either way, CHE is legit, not just a subset. Starbucks, which involves wet work, Amazon, which involves handling boxes in dusty warehouses, and nail salons for both techs and patrons alike, are producing ever more eczematous hands, and all it takes is 2 episodes per year or one lasting 3 months to be considered chronic. Are you ready? Path matters. Thanks to Omar Noor for the helpful breakdown published April 23, 2025 in Dermatology Times. Next is for those of you that have a patient with a face full of flat warts. We've all had one of these. Topical and procedural treatments like salicylic acid preparations and liquid nitrogen are irritating, ugly during the treatment period, potentially disfiguring in the post-therapeutic period, and can even cause the warts to proliferate and spread, especially in shaved areas because they disrupt the skin barrier. So what can you do? You can treat orally with isotretinoin. In this case, the magic formula appears to be 0.5 milligrams per kilogram per day for 12 weeks. At least that's what researchers in Mexico City found when they compared that dose to zero point 0.3 milligrams per kilogram per day in a double blind, randomized study published 21 April 2025 in Health Science Reports. It turns out isotretinoin's efficacy in this population has been previously published, and this study was more about optimal dose finding than proof of concept. But if you're like me, you've had patients with numerous facial flat warts and struggled to walk the tightrope between efficacy and unwanted iatrogenetic effects of our typical treatment modalities. Of the 19 patients in the higher dose group, almost 74% achieved complete response, and the remaining 26% got a partial response. That's not a shabby response rate, and these were really tough patients. Inclusion criteria were prior treatment for at least 3 years with at least two of the following topical retinoids, imiquimod, 5-fluorouracil, and or cryotherapy. So let that sink in. Accutane did in 3 months what multiple other therapies couldn't do in 3 years. Sure, the subjects experienced some cheilitis, but that's easily manageable and better than blisters and open sores on your face, right? Thanks to the authors for providing open access to their findings. Next, do you have an itchy old gal who swears she hasn't changed her laundry detergent? Ask her if she's started a blood pressure medication in the last 2.5 years. As the population skews older and a variety of eczematous conditions become more prevalent in mature skin, the itchy elder has become an increasingly common occurrence on derm schedules. But it's not just senescent cutaneous changes resulting in barrier dysfunction and xerosis that are to blame. Several studies over the years have shown that antihypertensives are frequently the culprits in new or ongoing eczematous eruptions in older patients. These rashes may be localized, especially on the lower limbs, or generalized. And the medication does not have to be new. In one study, the latency period for onset ranged from 4 to 30 months. So, which blood pressure meds should we look out for? Well, maybe all of them, as the hazard ratio of eczematous dermatosis in patients receiving any hypertensive was 1.29. But alas, correlation still isn't causation. So, calcium channel blockers, especially amlodipine in stasis dermatitis, and thiazide diuretics, especially hydrochlorothiazide, aka HCTZ, appear to be the worst offenders with odds ratios of 4.21 and 2.07, respectively. Smaller effect sizes are seen with angiotensin converting enzyme or ACE inhibitors, angiotensin 2 receptor blockers or ARBs, and beta blockers. And don't forget to look for stealthy combination drugs with increased risks, as lisinopril/HCTZ is a common combo. If you biopsy, spongiosis with or without associated psoriasiform changes and or interface dermatitis are consistent with this type of drug reaction. Working with the patient's primary care provider or cardiologist to change medications can be cumbersome, but in many cases, the reaction is dose dependent in lowering the strength of the offending agent with or without a coordinated increase in another may be enough to clear the rash while maintaining optimal pressures and avoiding exacerbation of polypharmacy and the potential adverse effects that come with symptomatic treatment with a topical steroid. Thanks to Warren Heyman and Katrina Abubara, whose survey of relevant literature on the topic for the American Academy of Dermatology Reading Room Selection published 14th of April 2025 on the MedPage Today, which served as a reminder of the importance of the medication list for dermatology detectives. Finally, does your alopecia areata patient want their hair back yesterday? Well, tell them to take their JAK inhibitor at bedtime. A study published April 17th, 2025 in BMC found that Eli Lilly and Company's JAK inhibitor, baricitinib, marketed under the brand name Olumiant, achieved higher ACR20 scores in rheumatoid arthritis patients when administered in the evening. The difference was especially striking among those taking the higher 4 milligram dose, with over 78% in the evening arm meeting the endpoint at week 12 compared to over 43% in the morning arm. So, why would dose timing make a difference? Well, because cytokines have circadian rhythms too. And TNF alpha and IL 1, the predominant cytokines in rheumatoid arthritis, are nocturnal. So, what does that have to do with alopecia areata? Well, the primary cytokine in alopecia areata is interferon gamma, which is also a night owl. And interferon gamma signals through the JAK-STAT pathway, particularly JAK1 and JAK2, which baricitinib blocks. Of course, we need randomized controlled prospective trials to replicate the RA findings in the AA population, but evening dosing is a free and easy intervention with a plausible mechanism for superior efficacy. And with similar adverse event rates among groups in the RA study, there appears to be no additional risk or downside to evening dosing. So why not make it standard practice when prescribing baricitinib? And ritlecitinib, or Litfulo for that matter. And while we're at it, IL-13, the key cytokine in atopic dermatitis, is generally more active at night as well. So you might as well consider evening dosing for upadacitinib, or Rinvoq, and abrocitinib, or Cibinqo, too. Interferon gamma is also the primary driver of vitiligo, so when JAKs get that indication, you already know what to do. Night dose. And if heightened nocturnal cytokine activity weren't enough, mast cells have a lower threshold of activation at night. So when your patient says their itch is worse at night, it's not just because they don't have daytime distractions to take their mind off of it. It's actually more severe at night. Thanks to the authors for giving us this JAK hack. And that wraps up our episode 6 of the latest Derm drop. Thanks for tuning in. And if you are interested in the articles, go ahead and hit that button to connect over to my LinkedIn, where these posts can be found with links to the original articles. Also, hit that share button, hit the thumbs up button, and tune in 2 weeks for the next episode. Thank you.